Well, good afternoon, everyone. Hello, and welcome to the New York DSRIP Core PPS Health IT Capabilities Required for Success webinar for providers and payers in New York and other DSRIP states. Thank you for joining us. We're very glad you could join us for this important topic. My name is Sean Kelly from GSI Health, and I will be your host for this webinar. At the end of the presentation, Lori Evans-Bernstein from GSI Health will facilitate a Q&A process. Before we get started, I just have a few housekeeping items to share. We've reserved some time at the end of the webinar for a Q&A session. If you have questions during the webinar, please enter them into the chat section of the GoToMeeting interface on your screen, and our presenters will address as many questions as possible at the end of the presentation. We'll make a recording of this webinar also available on our website in the next few days. If you should have any additional questions specific to your organization, please notify us via the chat function on your screen, and we'll follow up after the webinar. We'll also provide GSI Health contact information on the last slide in our presentation. Now we'll go ahead and get started. Our first presenter this afternoon is Lori Evans-Bernstein, President of GSI Health.
Thank you, Sean, and welcome everyone to our webinar. We have a lot to cover. It's only an hour, so we're going to jump right into the agenda. And we're going to spend just a tiny bit of time on the DSRIP goals and challenges in the current system and the progress made by health homes, critical health IT system components to support PPS mandatory domains, and then take the discussion down a level and focus on three topics specifically. One, how PPS health IT systems interplay with electronic health records and the statewide health information network for New York, or SHINY, meeting state DSRIP reporting requirements, and key concepts around patient risk stratification and predictive analytics, and then get to our Q&A. And the reason we chose those three topics for the deeper dive is because we think those are critical for PPS success, and then especially the state reporting and understanding your patient population with respect to patient risk stratification are key day one in April of 15. So that's why we chose to focus on those. So jumping right in to the goals of DSRIP. I think everybody at this point is so familiar with these, right? No small feat to just transform New York's Medicaid program, to bend the Medicaid cost curve, to ensure delivery system transformation.
Laura, I apologize. Maybe you should share the other screen. We're seeing your control panel. It might be larger for people to see.
How's that?
Great. Thank you.
All right. Sorry, everybody. Hopefully that's much bigger. So everyone's very familiar with the goals, and in order to achieve the DSRIP goals, we need to have the health IT systems in place to support the reduction in unnecessary admissions, readmissions, ED visits, to support medication management and adherence, to integrate medical, behavioral, social, and community resources, streamline post-acute care coordination, triage patient care at the right level, the right time, the right place, and the right priority. And the health IT solutions designed for integrated care programs like the health homes and now the PPSs must enable interdisciplinary care teams to collaborate and be aligned with the needs of the patient. They must give us meaningful insights from our data through different analytic capabilities that can be then injected into the clinical workflow so we have actionable information. We have to be able to engage our patients differently, not only in terms of communicating with care teams, helping them become an active participant in their care plan, but certainly having health workers that are linguistically and culturally aware of all the needs of the patient population. Turning to our current challenges and the significant progress we've made with the health homes. Just so all of you know where we're coming from at GSI Health, we're supporting 10 health homes in New York and many across the country with our care coordination solution. We started with Maimonides Medical Center in Brooklyn in the Brooklyn Health Home back in early 2012. It's been that long. And we've seen firsthand the significant progress with the Medicaid health homes as a key building block for the DSRIP programs. The health homes have been focused on the high need and high risk patients, like Charlie here, you see his picture, with many comorbidities and risk factors requiring care and treatment from numerous providers, agencies, community support systems, etc. So before health homes, this slide is depicting Charlie's very fragmented, uncoordinated care. The redundant questions, the multiple inconsistent care plans, the duplicate orders, the delayed information, lack of medication reconciliation. You guys know this all too well. And one of the things with the health homes is there's been major progress in really unifying Charlie's care and improving the multiple inconsistencies and siloed care plans for Charlie. Really unifying the care team and unifying a care plan that's been so important for the health homes and the progress that they've made. And we really see them as a key building block to the PPSs. There's also been a lot of preliminary data from the health homes, from the Brooklyn Health Home in particular, indicating pretty significant declines in hospitalizations. So moving to the critical health IT components to support PPSs, we put together a framework for performing provider systems. We talked about the goals. We think about the very high-level health IT requirements being in the sort of information and collaboration and information sharing realm, the data aggregation and analysis realm with multiple data sources. We're going to talk a lot more about that. Making sure we're also focused on clinical effectiveness and patient safety, ensuring the right care at the right place, the right priority, and certainly being able to have a lot of mobile tools, I think goes without saying, along with strong privacy and security protections. But what we really think is important to focus on is these key processes to meet the goals of the performing provider system. Understanding your patient population, identifying who they are, being able to stratify them based on high risk, rising risk, and low risk, for example. Lots of measurement and reporting. There's all sorts of state reporting requirements out of the gates, and that's one of the reasons why we're going to take a deep dive into that. Care coordination, patient engagement, clinical knowledge, community engagement, financial management. And the next slide really sort of builds out this health IT framework for PPSs, and it's really meant to be a guide to help support health IT system roadmap development, system selection, and really doing it in a way that's leading with the care functions and the processes, rather than just, you know, general system requirements or general IT capabilities. So you see on this slide the key processes that I noted at the top. And then underneath each of them are the care functions within each process. And then and only then an understanding of the health IT capabilities to support those functions. And we don't have time to go through all of this today by any means, but I am going to go through one example with respect to care coordination and the care functions within that process of establishing provider relationships, establishing social service and community relationships, establishing payer relationships, having access to real-time insurance information, identifying care teams, creating and monitoring care plans, ensuring medication management, managing referrals, having the right patient alert in real time when a patient shows up in the emergency department, for example, being able to do the right information reconciliation and tasking and paneling. So those those care functions within the care coordination process can then be further assessed to what the health IT capabilities need to be. So in other words, the system can or has. So in the case of care coordination, and again, I'm just going to go through three of the laundry list of care processes, or care functions rather, for the care coordination process to give you a little bit more insight. So let's take established provider relationships. So as the PPS builds a network of providers and community organizations willing to participate in coordinating care in multiple settings and facilities, clinicians and care managers will have access to a team with similar goals and objectives with respect to really coordinating care for your very large PPS population. And so what that means in terms of thinking about health IT capabilities, and again, asking the question the system can or has, and these are the following. The performing provider systems provider lists are available for all types of providers and facilities across the entire continuum of care, both within and external to the PPS. Having the ability to cross-reference the PPS's providers to the patient's provider network should there be misalignment. Ability to form interdisciplinary care teams and align that team with the needs of the patient. Ability to share clinical information among provider systems and the interdisciplinary care team. Accepting notification of patient encounters and adverse events in real time wherever they may be. So again, example of care coordination as the key process, the care functions within that process, and then the health IT capabilities to support that function. And again, we feel like this is a strategic way to focus on your needs, again, leading with what you all do every day and know in terms of the care functions, as I mentioned, rather than just, I think, getting lost in a sea of overwhelming, sort of very general IT requirements. So just to take another one, established payer relationships. The PPS and the MCO may be able to effectively and efficiently partner in providing care management and other services for selected patients. So moving to the right in terms of health IT capabilities the system can or has include plan-based care managers among authorized users of a care coordination solution as appropriate. Ability for the interdisciplinary care team to communicate directly with managed care organizations about a specific patient. Ability to allow transparency of patient information among the interdisciplinary care team and the managed care organization. And then the last example here is around medication management and medication reconciliation. Being able to ensure that a single list of the patient medications correlates with those that the patient is actually taking, contains no medications with unintentional duplicative effects, and ensuring that it's done in all settings of care. So then turning to the system can or has access to medication lists from multiple sources, and displayed together, highlighting duplications, incorporating patient supplied history, designating the reconciled list, having the system accurately reflect active medications, maintain history of previous medications, evidence that the prescription was filled, and certainly real-time alerting. So again, hopefully this gives just a good sense of how important and helpful this framework can be. Turning to the first more in-depth topic around how PPSs and health IT systems interplay with the shiny and electronic health records. And I really love this slide, and I love talking about the shiny. Some of you may know I was a deputy commissioner at the New York State Health Department. I was the first deputy commissioner leading the Office of Health IT Transformation, and I was the first mother of the shiny, so I have a special affection for it, and it is really critical to the work that we're all doing. And you see that depicted here, and the important interconnections with the electronic health records. And then above that, really the additional health IT solutions needed to support the PPS and all the goals in front of us. Certainly around being able to aggregate and analyze data, being able to do that with multiple different types of data, having the right analytics and business intelligence tools, the clinical decision support, and lots of different reporting, and we're going to talk more about reporting. Being able to take all those insights from data aggregated and data aligned and apply them and inject them into the workflow, which is the top level of boxes, and then being able to certainly take what happens at the point of care within the workflow and make sure it goes back into the analysis tools that are needed, so we really have a closed loop and can drive the meaningful insights into actionable information. And then there's another electronic health record box at the top, and the ability to really build bridges and align the electronic health records with the performing provider systems health IT solutions through single sign-on, through patient contacts if that's possible, with respect to the EHR vendors, and really making sure all the critical applications are aligned. And I think some of the key imperatives here are that the PPS solution really must have interoperability services, almost like an HIE-like capability, to really connect to and leverage the Shiny as much as possible. Many PPSs will have multiple HIEs to connect to. There'll be multiple MPIs, and there needs to be a way to reconcile that. There'll be lots of clinical information that's going to be critical to analytics, to lots of different reporting, to clinical decision support, and being able to leverage that in a way where we know we're getting lots of different CCD formats across multiple different types of EHR vendors. Ideally, having that information be integrated through the Shiny and then interfacing into the PPS solution is going to be really critical. But dealing with the variation that will come from multiple HIEs. Being able to leverage any existing care managers that may be in place in terms of data integration and migration. Again, having a solution that has interoperability services or this HIE late is going to be important to take advantage of that. And also being able to align clinical data with claims data, with hospital administrative data, with sort of what we've been calling care coordination data is going to be key. And then certainly, obviously, leveraging the years of investment that New York State has made in the statewide health information network. Having a solution that can maximally take advantage of that by having the right components underneath will be essential. But then the other point here is that certainly, while everyone's working hard connecting their electronic health records to the Shiny, and while we're working hard to connect our solution to the Shiny, that doesn't need to happen right away. There's not a prerequisite to have an EHR, frankly, or even have your EHR integrated to begin using a PPS solution that's going to give you value very quickly and to allow you to begin to meet your state reporting requirements day one, and to understand your patient population day one. So with that, I'm going to turn it over to Lee Jones, the CEO of GSI Health, and he is going to take us through the next few topics that we have. And I'm just changing presenters here. Just give me one. Here we go, Lee. It is coming over to you. You have it?
I do. Are you able to see it? So thanks very much, Lori. I appreciate the transition, and all of the points that you made are certainly important ones. I'm going to talk about two topics, and the first one being the state reporting requirements. And so by now, many of you likely have reviewed the DSRIP's requirements for reporting, have been wrestling with what projects you're going to undertake, the things that you propose in your applications versus the things that you want to collaborate with your neighbors on, et cetera. And so I think that this is probably something that many of you are familiar with. There are 4 different domains that cover the spectrum. Domains 2 and 3 contain some mandatory reporting. Domain 1 is overarching and is reporting about the project's progress itself. And so each of the domains has some set of measures of various types, some of them quantitative, some of them from survey data, some of them just assessing the state of things. But all of the metrics that are under, in particular, domains 2 and 3, and 4 to some extent, are going to be important for you to really jump on top of, to get your data in place, to understand what you're going to be measuring and on what frequency and who's going to be contributing, et cetera, et cetera. And so we're going to just highlight 2 things for you to think through as you start down this process. So the first, I'm using an example from the domain 2 to create integrated delivery system, which is mandatory for all of the different projects. And one of the measures that's listed there is getting care quickly, routine and urgent care appointments. So the point that I want to make here is it's one thing to understand how you're going to accomplish this and be able to allow the patients to get care quickly, but what you need to also consider is how are you going to integrate that workflow that you have in mind with the tools that you use so that it's efficient, it's effective, and you capture the appropriate data that will allow you to substantiate what you report on this kind of metric. And so some key enablers are providing a good workflow and continuous training so everyone knows what they're doing, making sure that the software you choose is strong in key areas, patient engagement, alerts, care steps, data integration and receipt and display, etc. And so this, while the measure gets at one thing, the process to actually measure it and to implement it is a little broader. The second example here is taken from Domain 3, the Behavioral Health Project, follow-up after hospitalization for mental illness. This is probably a familiar measure for some of you who have done this in HEDIS or done it in other contexts. And the point that I want to emphasize here is while you may have done this in other contexts, it's not necessarily true that those contexts and how you've done it there will translate into DSRIP. You need to make sure that you take into account the data frequency. Some of you may be using claims data exclusively to calculate these measures, whereas now you can move to a more collaborative model and have other factors. The information that you're getting from your traditional data sources may not take into account the interventions and care steps that you'll be using in care coordination, and those need to count toward a measure like this for follow-up after hospitalization. And so you need to look beyond your existing systems and assess all of the different places where you will be having various kinds of encounters, particularly if you have various kinds of providers, and ensure that all of that data is captured in a way that can help you to report accurately on a measure like this. And so the takeaway for those measures is that it's a planning process. It's not just a checklist of things you have to report, but rather it's a plan for how you're going to integrate in a holistic way your workflow, your reporting, and your data capture. Next, I'm going to talk a little bit about population segmentation because this idea is prevalent and lots of people immediately reach to a number of different manners to solve it. And I want to just make sure that we highlight a few things that you should be considering. So why is stratification important? The bottom line is efficiency. If you have a limited number of care team members and care workers, such as care managers, in a large population, you need to be able to segment them somehow so you can focus your resources and energy on the most appropriate places so that you both deliver the most efficacious care and you optimize your objectives for your program. And so stratification, setting priorities among the different segments of the population is a way to do that. So in this discussion, I'm going to refer to a few terms. So I wanted to give some working definitions for us. One is, what are we talking about when we talk about analytics? And that's really just a method to perform some sort of data analysis. There are a number of different methods that you already likely use or will be employing in the context of DSRIP. I'm going to just use a few terms here because I'll refer to them in different places along the way. Characterization is really segmenting or querying against the population to create a group based on some criteria. So if you're used to querying a database, that's an example of doing a characterization. Association is trying to determine the contributing variables that are correlated to something else. So if you're familiar with the idea of regression analysis and the dependent variable and some independent variables that contribute toward it, that's what association is. How well does one thing that I can observe track with another thing? Predictive analytics is really a classification system, and it allows you to estimate some sort of future value for some dimension of patient care based on the patterns that you see in the population. And that can be accomplished a number of ways. Two that I'll talk about today are learning by example, and that really means looking back. If I understand what objectives I'm interested in, I can look back through time in history of my population and see what patterns lead to it and build a model that way. Another is learning by observation. When I don't understand the exact objectives that I want to track, I can just look at the data at hand and see how things tend to gather together and form a model in a more dynamic fashion. So then when we're talking about population stratification, it's really just dividing the population up by some set of criteria. And when we say risk stratification, which is something that I think will be important for you in particular with the DSRIP context, we're just saying the criteria that you use is the risk that the members of your population will realize a certain outcome that you're interested in either realizing or preventing. And so we have a little bit of an overloaded term when we talk about risk stratification, because it's not just a one-size-fits-all kind of concept. So when we talk about risk stratification, we might be talking about making some discrete set of risk classification criteria, like how much money has been spent, or rather, what's the cost of this patient? What's the disease state of the patient? What kind of follow-up activities have happened? Whatever the set of criteria are, you can set different sets and then partition the population according to that criteria. So, for example, rising risk patients might mean that you have two or more comorbid conditions, yet they're managed well. Whereas high risk, it might be 3 or more comorbid conditions and they aren't managed well. But risk stratification can also mean the likelihood that an outcome will be realized in the future given some confluence of present-day factors. So this is typically expressed as some percentage or likelihood, such as 54%, et cetera. And an example here, the likelihood of patient Jones being admitted to a hospital in the next 12 months is 0.54. So just for the sake of clarity, I'm going to call the first category where we look at different criteria to segment a population a risk factor as opposed to risk, and I'm going to reserve the word risk for calculating that sort of likelihood. So when we're talking about risk factor stratification, I mean criteria, and risk, I mean calculating a likelihood. So when we look through these two approaches, risk factor stratification can come from all kinds of sources. Risk factors can be from you. If you have a program that has some history and a theory on the patient care, you may have a number of risk factors that you think contribute toward the outcomes of interest, and you may use those as your segmentation criteria. They could come from the medical evidence and literature or any other number of sources. They might be numerical, so this isn't to apply that they're totally qualitative. They could be quantitative and be a score or a scale of some sort. And they may afford you a little bit of flexibility in designing the program, because you can set this criteria and reset it and really easily partition your population. When we talk about risk stratification, calculating a likelihood, we typically are arrived at through some computational method like regression analysis or clustering. There's usually some dependent variable or the outcome that you're interested in, and there are a number of other factors that contribute toward that outcome. And it can be expressed as, some sort of likelihood or rate that that outcome will be realized. But in order to stratify by a risk, in this sense, you have to understand what the outcome is. And you may know that in advance, or you may not, and therefore you would use some different techniques to accommodate those two. So here we see an example of risk factor stratification. You can see in low risk, low resource use, a healthy patient with significant risk factors, whereas high risk, you might have high resource use, patient has multiple chronic diseases, significant risk factors, and complex treatments. Contrasting that with risk stratification, we can see that the patients who fall into the different bins have a different likelihood of having an admission within the next 12 months, and you can partition them out that way. So what can we conclude from all this? Well, that when we talk about stratification, there's no one way to do it. There are several ways, and you have to design how you're going to approach stratification. It's a process. It's not an on and off switch. You'll need to spend some time thinking through exactly what you want to achieve, what you want to measure, and how you'll do that. And then you're going to have lots of opinions about how it can be done, from other programs to vendors to academic institutions and literature, et cetera. There are going to be lots of people who want to explain how you can segment your population in an appropriate way. And at the end of the day, you have to make your own decisions, but how is it that you can find the real melody that's going to support you amidst all the noise that people have? And that's really what we want to talk about today. We want to try to give you a way to look through and in discrete steps, analyze what you need to do and behave appropriately. So I'm going to go through a few steps to just describe this idea of risk stratification and give you a path that you can take in order to try to design and think about your program. So when we start, it's all about outcomes, methodology, and data. If there are specific outcomes that you're interested in tracking to and to partition your efforts and your energies according to them, then from the outset, then you can state those, or if you're not sure, you can discover them later. DSRIP has an overarching goal of reducing the number of emissions by 25% across the term of the project, and so that might lend itself to the number of emissions in a certain period being one of your outcomes, or a percentage reduction being an outcome. DSRIP also has a number of domain measures, like this one, for example, the PQI number 90, which is a composite of different kinds of emissions. And those may be something that you want to track to as an outcome as well. And so you could track to both, or you could make some sort of composite among them, et cetera. Then you need to understand the methodology. Garbage in, garbage out doesn't just go for data, it goes for methodology as well. All of these different characteristics of your data and what outcomes you want to track will have different caveats for how you calculate them and how credible your end reports will be. And then, of course, data has to support whatever your decisions are. So when we're looking at processing the data that matters, typically we'll have some outcome, as is on the left-hand side here, and you have some determinants or things that contribute toward that outcome in the medical or behavioral space, and maybe some processes, some activities that you're going to do in order to also influence that outcome. So for example, we might choose our outcome to be PQI number 3, which is one of the DSRIP measures, as our outcome, and we could also choose another measure, the comprehensive diabetes screening, as a process measure that leads to that outcome. And so you could even have a complicated determinant as a part of the process. So when we do that, we set up a model that will help us to calculate among all the data elements the outcomes that we're interested in. So we can assign a variable y here for our outcomes of interest, and x represents all the different factors that we think contribute toward that outcome of interest. And then we need to understand beta here, which is the level of contribution that those different factors have on that outcome. And this is typically done using some sort of regression analysis and the claims data sources and clinical data sources that we're all used to and that you might find through a channel like the Shiny. But when we're talking about going into a more collaborative care model, we really are talking about additional things being considered. So there may be additional social determinants or additional coordination determinants that contribute toward those outcomes. You want to make sure that those are factored into your model and that they're captured as a part of a reliable data stream that can be integrated with your claims, with your clinical data, et cetera. So if you're in the health home business, you probably understand the importance of those factors, and you can't neglect those coordination data. Once you have your model established, you apply it to your existing population, and that population can then be segmented into whatever bins you think are appropriate. So in this step, you would set your thresholds. I've set high risk as greater than 75% according to model, medium risk and low risk similarly. And now everyone in my population can be put into a bin or strictly ranked, whatever is important. And similarly, I need to be able to classify new patients as they arrive. And so the system that I use should be able to take in a patient and assign them something, and as patients progress through my course of care, to be able to reassign them to the appropriate classification so that it's not a tremendous back-end process to continually and dynamically assign patients. You have to change your model and calibrate it over time, especially when you're looking at a learn-by-example approach like a regression that assumes the characteristics of a population are essentially similar and constant. So as you're changing the dynamics of your population, you'll want to recalibrate and reset the model. And when you do that, that's going to result in different classifications of your existing population, and that's fine. And you will probably want to keep a longitudinal history of all of those different classifications, because it will show how your program has evolved and how your patient population has evolved. And then once you have all of those different stratifications, we want to make sure that even within those, we're putting our energies in the right place. And so you can do some level of sensitivity analysis in order to understand if there are some who may be in a particular classification who are likely not going to be responsive to your planned interventions. And so if there's nothing I can do about a patient to reduce their likelihood of having a certain outcome, then I want to focus my energies with the patients that I can make a difference on. And once you have that level of stratification, there are other factors that you want to use in order to assign it appropriately to workflow. So when you have care managers or other members of the care team who are going to be responsible, there are other factors that are beyond the macro goal that need you to further stratify. You might go after people who've had recent encounters, or who are members of health home, or who have an alignment with their case and the particular skills that your staff has. Whatever that is, your system needs to help you further stratify so that it can fit the workflow in a specific way and not just a generic way. So when you approach your stratification this way, you could have a number of different outcomes, and each one of those outcomes will have their own set of stratification. So you stratify by outcome. So what happens if I have a couple? How do I use them in a uniform fashion, given that they are separate scales, et cetera? So in this example, I might have a high risk of admission stratification, and here are my high-risk ones according to that scale. I might have also done a risk factors stratification, and I found there was another population. And I can combine these in different ways to tell me different things. So if I take an intersection of those groups, maybe those are the highest risk patients because they fall into both different categories of measurement, and I want to approach them first. Or maybe I just take the union of them and put all the patients together and say this is sort of high risk for compound outcomes. And you can envision having a number of these different stratifications across different outcomes and doing these kinds of combinations to find who you should actually be spending time with. So just as a sidebar, we talked a lot about this risk stratifications that seem to rely upon a regression technique. I wanted to just talk about an alternative approach really quickly that doesn't go that route, and that is you may try to do a cluster analysis to determine where the natural clusters of patients are to find their similarities, or you do some risk factor stratification. And you might do that on all the patients who are currently in a bad state, one that you would think is critical now in today's terms. You can then project back in time to see what those patients looked like 6 months ago, 1 year ago, et cetera, given that you have their medical history. And when you project back in time, you can then take your current day patients and see how similar they are to these critical patients back before they became critical. And you can see who might be on the path to criticality. It's another form of doing a predictive analytics, but you don't have to use regression analysis in order to do it. And you also will discover if, when you project back in time, if the patients tend to diverge and are no longer similar, there may be multiple paths that you discover that lead to this critical assessment. And so that's just one alternative way to the way that we've been discussing it so far. So those are some steps that you can use. We put together a little infographic to try to summarize the 7 steps that I just discussed, and we're happy to make it available to you after the webinar. But I think the big takeaway from this discussion is there's more than one way to do it, but there are some common things that you can do to help you get a clearer picture and to be able to cut through the noise and appropriately design your risk stratification. So with that, we've concluded the delving into our specific topics, and I'll turn it back to Lori for questions and answer period.
All right. Thank you, Lee. So if you have questions, you can use the chat function. There are a handful there already. A lot of housekeeping ones around copies and recording, and all of that will be available, I think, through the website. Or Tim, how will we make the recording and the slides available?
Yeah, we'll post a link on our website within 3 days, so folks can download a copy of the actual recording at that time.
Okay, great. All right, so let's start with some questions. So let me see here. I might sort of group some of these together. So one is given your experience, what data elements could we obtain from the Shiny? And the second, and these are related, believe it or not, how do you coordinate the complex care plans from all different care team members? So the reason why those are related is because the data elements from the Shiny, in our experience, are based on the continuity of care document standard. And Lee or Parag can probably rattle those off, and I'll turn it over to them in a second. But the point I wanted to make is that the standard continuity of care document that is the common data sets that's shared between electronic health record vendors and the Shiny, that standard does not include care plan and assessment information. And so it really underscores the importance of having a coordinated care plan that is a single pane of glass that all members of the care team can see at all times, that's dynamic and up to date, has integrated assessments that auto-populate issues and care steps or interventions on the care plan. There's a draft standard to add the care plan and assessment information to the continuity of care document that electronic health records transport in a standard way. We actually participated in that standard development and a pilot, but just like with lots of standard development and certainly the experience with the continuity of care document, it does take some time to mature. It's probably a good 4 to 6 years out based on our experience. And again, it really underscores the importance of having an interdisciplinary care team that's dynamic and available. So I'll stop and see if Parag or Lee can comment specifically on the data elements from the Shiny.
I think your summary is accurate. You know, the standard is the consolidated CDA, the one that you were referring to, that starts to take into account the care plan activities. So even the authors of the CCD recognized that there was a deficiency when it came to the care plan. You know, although, you know, people have gotten creative over time on trying to represent things in various ways, there's now a formal, you know, draft standard for trial use on the CCDA 2.0, and that contains a particular document for care planning. And, you know, I think that one thing that we've said in giving feedback on that document is it's certainly a wonderful start, and it does a lot to represent concepts that we believe are consistent with care planning. But there are still some other things. When you talk about collaborative care, there's a difference between having transparency among the providers and having the providers actually collaborate and contribute toward a common care plan. So I think the standard right now could get could have a few more features, and we've given feedback to support collaborative care a little more strongly than it does today. But I think what you said, Lori, was was pretty spot on.
So another related question is just on this theme, and I'm just going to try to find the ones on this theme. Can community resources access your coordinated care plan and add their own notes about the patient? And yes, the care plan is it's available for all members of the care team. There's the ability to bring community resources on and off the care team as appropriate and have access to the care plan. There's different access levels, so you can limit things depending upon the type of community resource needed. But yes, I think that's a really important piece for leveraging and achieving the goal of integrated care for the PPSs, bringing together medical, behavioral, and social components. So let's see, turning to another one, what capabilities do you think a PPS needs on April 1st? And that's a great question, and probably one that everybody's wrestling with. I think the reason, as we mentioned in the beginning, the reason why we focused on meeting the state reporting requirements and being able to understand your patient population in terms of segmentation and stratification, we feel those two are pretty important to have day one. I think that the state reporting speaks for itself in terms of having that drive the payment mechanisms. And then certainly, absolutely needing to understand the patient population is critical. I think with the health homes, we knew who the high-risk, high-need patients are, and it made it actually made it a nice starting point to know who those are and really focus on building clinical partners and community partners, starting to form care teams, having coordinated care plans, for example. And so I think those are key. I'd also probably throw in the high-risk care management, given that those represent a significant piece of the cost and sort of the overall sustainability that districts going to achieve. And then I think there's a lot of things that can be feathered in after that. Certainly, I think the care management for all that's being touted can be feathered in. A lot of the other sort of clinical effectiveness components can be feathered in, and what I mean by that is just to contrast that a lot of the workflow pieces are very sort of efficiency based, and that it's very key to sort of break down the silos, break down the fragmentation, don't duplicate resources, ensure the collaboration needed. But the clinical effectiveness is more in the vein of what are the best treatments for this patient, and how do we make sure that the stroke doesn't happen in the first place, for example. And I think if we don't get to that clinical effectiveness piece, we're not going to be able to truly realize the cost savings that we need. But I think that can be really feathered in as we go. Let's see. Here's some other ones, and I fear we're not going to be able to get through all these, so we'll try to figure something out, because there's a lot of great questions here. Let's see. Does the GSI Health solution use the direct protocol? Yes, we do. It's part of our infrastructure. We connect to other HISs, other health information service providers. We're connected to many now, and that's a great way to have a pretty quick network effect for sharing patient information securely. So sending around copies of a care plan, for example, or a continuity of care document. And we have a messages client in our solution, but certainly any direct enabled solution can really sort of participate in the exchange. So as EHRs become more direct enabled, it's an easy way to share information. As NICE rolls out its direct service, its HIS, we certainly are the first ones in line to connect there through the HealthX solution. Any other comments on that, Lee? Or
No, I guess one other thing I would say is even if you don't have a use case that requires you to go out of network, so to speak, to need to send something to another HISP or someone who's serviced by another HISP, even the internal communications within our platform uses the direct standard, so you can have that same assurance of security and not have to think about communicating in different modes.
Right. So here's another one. Do you know if there are provisions, waivers through DSRIP around HIPAA when sharing mental behavioral health data? I don't know. I don't think so. I think that we've, with our health home partners, have had a lot of experience in this with the health home program in terms of the consent requirements, in addition to being able to lock down some of the Part D information. Let's see. My goodness, it's hard to. How do you manage the consents that patients need to sign to share their information and managing when consent has been withdrawn or expired? So, great question. We have a patient consent capability built in to our solution. There's the ability for care managers or other users to attest to that consent in the system and also be able to store the physical consent as well if that's desired. And then that consent essentially is the window that opens for that particular person to view the patient's information, and it also is sent to connected systems, health information exchange, in some cases directly to EHRs. And so in Brooklyn, for example, we pass that consent to HealthX. They ingest it, and then they send all the clinical data that they have, different continuity of care documents, back to us, and we sprinkle it through the solution. Some goes into the care plan, into assessments in particular. Some goes into a patient summary, a clinical information summary. All of it goes into the data warehouse for reporting. And then if the patient's been withdrawn, then the user simply goes in and unchecks the box for that particular organization, and then there's no more information that can be shared about that patient. Let's see here. What data is needed to comply with the state reporting requirements for the mandatory domains? Lee or Parag, do you want to take that one?
Yeah, sure. So a couple of mandatory domains are to create the integrated delivery system. That's from domain 2, and there is one in the domain 3 clinical improvement metrics behavioral health project. If you go through some of the details of the metrics that are required for reporting, it's really a combination of your care coordination platform as well as the claims data. So listing, we can be on this call if I start listing out all the types of data, because this is quite a diverse set of information. But overall, anything that is can be supported by claims, and especially what's captured in whatever care coordination system PPSs will be using. And for example, some of the domain 3 create an integrated delivery network metrics rely on making sure there is an interdisciplinary care team and the patient engagement was facilitated. Some of that data really depends on what type of tools and workflow the PPS decides to implement in their community. So.
Okay, great. And then I think we just have maybe time for a couple more. So one, can you explain your scalability of implementation in a short period of time? From the technical perspective, we're not, we have a massively scalable architecture. From the people, the human resource and implementation perspective, which is I think you're getting at, we have a partnership with a major consulting firm to be a staff, to basically be staff extenders and give us the boots on the ground, the feet on the street that are needed to do implementation in such a short time. We have a robust methodology around meeting with the different stakeholders involved, understanding current workflow, coming up with a new workflow, doing training based on that workflow, going through a very straightforward IT checklist to make sure the quote website is isn't having any slowness or any problems, and so we're prepared to take advantage of the opportunity. Let's see if there's one more here. There's so many. So I'm just looking at the clock. I know everyone probably is running already to their next thing as it approaches 1 o'clock. We just wanted to thank everyone for attending. We hope it was informative and helpful for you. And we will try, there's a lot more questions here, so we will try to do our best to get these answers out to the person that asked them, and then perhaps share them with the whole group. So thank you very much. Have a great day, everyone.